Hello and welcome to today's AOSR Education and Training Committee webinar on brain tumor imaging and advanced techniques. We have a very exciting program and very experienced and very talented speakers that will be sharing with you from their expert knowledge today. And so without further ado, let me just introduce the first speaker for today's webinar. The first speaker for today's webinar is Dr. Yoo, who is a clinical associate professor working at the Seoul National University Hospital. Today, Dr. Yoo will be sharing with us about DSE, DCE, and ASL for brain tumor imaging. Dr. Yoo has areas of interest including lymphatic MR, perfusion MRI, and brain tumors. And she's also deputy editor of European Radiology. And I think all of us are very excited to see what she will share with us today on advanced imaging techniques for brain tumors. So without further ado, Dr. Yoo, please.
Thank you, Professor Goh, for the kind introduction. I'll start sharing my slides. So yes, I'll begin my talk on DSC, DCE, and ASL perfusion-weighted imaging for brain tumor imaging. First, in the first half of the lecture talk, I'll be concentrating on the basic physics of the perfusion MRI. So as you all know, DSE PWI is T2 star-based imaging, and the strongly paramagnetic gadolinium induces susceptibility effect on T2 star weighted imaging and causes dark signal intensity on the imaging. So we start with the signal intensity, and which is converted to the change in relaxivity, which is then converted to the concentration of the contrast agent within the tissue and converted to various parameters in the perfusion weighted imaging. So as the first step, as gadolinium arrives in the brain and washes out in the first passage, you can see the transient loss in the signal intensity, starting from the large arteries, parenchyma, and the large intracranial veins. So here's a typical signal intensity time curve as the gadolinium arrives in the brain and washes out in the first passage. So in the first, after you get the signal intensity time curve, it's converted to the change in relaxivity curve, as shown here, or the relative concentration of the contrast agent. And then from the concentration time curve, the area under the concentration curve corresponds to the cerebral blood volume. And you can also get the time to peak from the curve. And going back to the delta or relaxivity time curve, you could get the CBF by applying the deconvolution using the arterial input function. Oh, sorry, apology for the distraction. So from the after you apply the deconvolution using the arterial input function information, you could get the CBF from the curve. And when you divide the CBV by the CBF, you'll get the mean transit time parameter. Next, that was just brief introduction for DSE. And next, moving on to DCE, it's T1-based technique where you also use the strongly paramagnetic gadolinium agent, but this time it causes T1 shortening, as you all know, which induces a high signal intensity on T1 weighted imaging as shown here. So you can see the dramatic contrast between the tumor tissue and the healthy tissue. And from using the DCE, you can derive many quantitative and semi-quantitative parameters as shown in the table. And of those, the three most popular ones are K-trans, VE, and VP. And the K-trans corresponds to volume transfer constant between plasma and extracellular, extravascular space. And the VE corresponds to volume of EES per unit volume tissue, whereas the VP corresponds to blood plasma volume. So to get the three parameters, you have to use a specific model. And the most popular model used to derive the parameters is the TK model, where it assumes where it assumes two compartment model, compartments within the model. And it assumes the equilibrium of contrast media between the plasma and EES, as shown here. To get the three parameters, we have the signal intensity, as I mentioned before. So this is the starting point, which is converted to the T1 relaxation time before and after the contrast injection, and the T1 values, relaxation times, are converted to the concentrations, tissue concentrations, and the plasma concentrations, which are then converted to the K-trans, VE, and VP parameters using this complicated equation. So I don't expect anyone to memorize these equations, but just wanted to give you a brief concept of how the signal intensities are converted to the parameters of interest at the end. So what do the parameters actually represent in terms of the tumors? The VP, which is the blood plasma volume per unit volume of tissue, is thought to reflect angiogenesis for tumors, whereas the K-trans and VE, which reflect the volume transfer constant between the plasma and ES, or ES volume per unit volume of tissue, are thought to represent the imaging biomarkers for BBB permeability. And next, moving on to ASL. In ASL, the labeled water molecules reduce the longitudinal magnetizing vector, resulting in the drop in signal intensity. So you have more pronounced reduction of the signal intensity in the regions with higher perfusion, and subtracting the control label image from the control image will give you the CBF map using the equation shown at the bottom. So you have to scan twice, one without any labeling and the other one with the labeling at the level of carotid bulb. So although ASL provides only CBF value in comparison to other two perfusion-weighted imaging, which provide many other values, it definitely has some advantages over more commonly used DSE MRI in routine clinical practice. So going over one by one. First, ASL provides absolute quantification of CBF value, and is totally non-invasive. It does not require any contrast agent, which will allow you for repeated measurements in one subject, say, for example, in seizure patients. And it's less sensitive to susceptibility artifacts, and it can be used also outside the brain. So it definitely has some several advantages over the DSE MRI. Now, in the second two-thirds of the talk, I'll be dealing with some clinical applications of the three perfusion-weighted imaging in brain tumors. So before we go into the clinical application of DSE, let's just take a brief look at how blood vessel overgrows in tumor cells. So as the tumor starts growing, showing overgrowth, it'll secrete VEGF, which is a commonly known growth factor, to all of you. And that factor increases blood vessel expression and induces movement of the vessels to the tumor. And the result would be the increased blood supply to the tumors. And the phenomenon would be called angiogenesis, which all of you would be familiar with. And this results in increased CBV on DSE perfusion-weighted imaging. So the characteristic would be used to differentiate typical high-grade gliomas from low-grade gliomas, and high-grade gliomas from the other common CNS tumor, primary CNS tumor, lymphoma. So in high-grade gliomas, the increased angiogenesis and dilatation of pre-existing vessels would result in increased cerebral blood volume, as shown in the typical example at the bottom. So there was a typical necrotic mass in left temporal lobe, which had diffusion restriction at the enhancing portion and increased CBV, reflecting the angiogenesis at the enhancing portion of the tumor, which is the most aggressive part of the tumor. So this was a typical example of GBM IDH wild type, WHO grade 4. In contrast, WHO grade 2 astrocytoma IDH mutant, you'd see some tumor-like features such as some mass effect as shown here. So there's a T2 hyperintense lesion at right frontal lobe with a bit of mass effect, but no definite contrast enhancement, no definite diffusion restriction, and no definite CBV increase. But this was diagnosed as a tumor of this specific pathology. So you can see a dramatic contrast between the low-grade and high-grade gliomas in terms of the CBV map. Here's the other one of here's a typical example of lymphoma case. So you would have a very homogeneously enhancing lesions, multiple lesions around the ventricle, which is a typical location of primary lymphoma. And the lesion showed diffusion restriction due to increased cellularity. But unlike the high-grade gliomas, it did not show increased CBV relative to the normal appearing white matters. So this is a typical example of a primary lymphoma showing high cellularity, but no definite angiogenesis as in high-grade gliomas. So CBV is definitely a key player in differentiating high-grade gliomas from lymphoma. And moving on, it could also be used to differentiate radiation change from progressive disease. And here's a brief schematic diagram of how low-grade astrocytomas and grade 4 astrocytoma are treated in the routine clinical practice. And in the first part, in the previous few slides, I've shown you that CBV can be used to differentiate the low-grade from high-grade gliomas. But as you can see in the next half of the schematic diagram, it can also be used to differentiate the radiation change which could occur during the treatment process from progressive disease. So moving on, getting more deeper into the specific type of radiation change, the phenomenon called pseudoprogression occurs in the subacute stage of RT change, and its peak incidence is at 1 to 3 months after CCRT. It more commonly occurs in the tumors with methylated MGMT, and it resolves spontaneously without any change in the current treatment. So here's a typical example. You can see a new enhanced lesion at the right temporal lobe, and with continuation of the existing treatment, it spontaneously disappears, and it was retrospectively diagnosed as pseudoprogression. So at this stage, it's very confusing whether this is a true progression or pseudoprogression. And for that, DSC can also play a role in the differential diagnosis. So here's an example. Before CCRT, just after the surgery, you can see the surgical cavity at right temporal lobe without definite measurable enhancing lesion. But 1 month after the end of CCRT, we saw new enhancing lesions at right temporal lobe, which did not show any significant diffusion restriction or increased CBV relative to the normal appearing white matter. And you can see that the lesions spontaneously resolved 4 months later. So it was compatible with the pseudoprogression, and the CBV map at the time of the appearance of the new enhancing lesions was kind of helpful to differentiate the pseudoprogression from true progression. And in contrast, this case also did not show any measurable enhancing lesion just before the CCRT, but developed new enhancing lesion at the surgical margin. But in this case, had increased CBV and no definite diffusion restriction. But because of this, we were kind of worried this was a worsened feature for the progressive disease. And you can see in the follow-up, there was a growing size of the enhancing lesion, which was compatible with the progressive disease. So again, at this stage where we had the growing or newly appearing enhancing lesion, the CBV map was helpful in differentiating pseudoprogression, which is a form of RT change, from true progressive disease. And just for the RT change, it can also appear at the late stage of the radiation. For some reason, I do not see the part of the slide, but I'll start continuing to see what happened. So anyway, it was also tested in the 50 patients who had new measurable enhancing lesions more than 6 months after complete response following radiation therapy. And this study analyzed the normalized CBV value and the proportion of dark signal intensity on SWI within the enhancing portion to see how they had how they performed in the differential diagnosis of late stage radiation necrosis and the progressive disease. So the recurrence it turned out that recurrence shows significantly lower hemorrhagic portion and higher mean normalized CBV, or the 90th percentile of the normalized CBV, as compared with the radionecrosis. And the combination of the two resulted in the approximately 82% of accuracy in differentiating the two. So here's a typical example. This grade 3 astrocytoma had new enhancing lesion 14 months after CCRT completion. And this lesion showed minimal hemorrhage in the enhancing portion and increased normalized CBV, 90 percentile of the normalized CBV, with the actual value corresponding to 5.13. And the histological specimen showed just a bit of hemorrhage, not too much. And this case corresponded to the recurrence. In contrast, this one had also new enhancing lesion around the surgical margin 18 months after the completion of CCRT, but had quite a bit of hemorrhage in contrast to the previous one, and my elevated normalized 90 percentile of the normalized CBB, but not as much as the previous example, and was shown to have multiple hemorrhages on the specimen, and was confirmed as radionecrosis. So yes, radionecrosis tends to have more hemorrhage and less of the elevated normalized CBB. And moving on, it could also be used to predict the prognosis of the diffuse glioma. And this study evaluated about 200 adult-type diffuse glioma grade 4 patients who had undergone the standard treatment, and aim to develop 2 NNU-net deep learning models for prediction of early local progression in the patients. And one of the model used conventional MRI alone, consisting of FLAIR and contrast enhanced T1 weight image, and the other one, multiparametric MRI, included DSC perfusion weighted imaging. So here are the schematic diagrams. In the conventional image, we had the FLAIR and the contrast enhanced T1 weighted image fed to the training model, and the labels were manually drawn within the non-enhancing T2 hyperintense lesion, with the reference to the true recurrence at the follow-up MRI. So it was the local progression areas were manually annotated, and these 2 information were fed into the conventional model, whereas those, in addition to the CBB, were fed to the multiparametric MRI model to see how they differ in their ability to predict the local progression. So here's a typical example where the normalized CBB map information was kind of helpful. And in this example, you see a necrotic enhancing mass and some surrounding non-enhanced T2 hyperintense area. And there was a definite increased normalized CBV in the enhancing portion, but also there was some mildly increased normalized CBV at the other non-enhancing T2 hyperintense portion. And the model correctly predicted the area of local progression by a small dotted area, although probably the DICE index was not high, because there's an obvious difference in the area predicted by the model on the true area of the local progression. But still, you can see where about the tumor show the local progression. And the model actually doubled the sensitivity, but the specificity did not significantly differ between the 2 models. So we kind of found it helpful to include the CBV in the context. And moving on, DCE could be also used in the clinical context to differentiate high-grade tumors from low-grade tumors or radiation change. And the explanation is given in the slide. So for high-grade tumors, you would have high leaky vessels through angiogenesis, which would show high permeability and lead to high contrast leakage. But in low-grade tumors or radiation change, the degree of angiogenesis would be normal or low, or leading to low permeability and almost no contrast leakage, as shown in the slide. So using the characteristics, it was used to predict the grade of the gliomas. So in this first paper, which was published in 2014, it tested the value of the DCE parameters, 3 popular DCE parameters derived from the entire tumor volume in the 28 patients with confirmed gliomas, to see how they perform in predicting the grading. And the results show that as you increase the grade, there was a definite increase in the KTRS and VE, the imaging biomarkers for the BBB permeability, and definite increase in the VP, which is the biomarker for angiogenesis. So that kind of makes sense. And here are the other graphs also showing the differentiation between the grades. And in the multivariable logistic regression, the 98th percentile of the K-trans was shown to be the only independent predictor. In the next study, our colleagues studied the value of the DCE in differentiating true progression from pseudo progression at the subacute stage of the treatment. And they've shown that the true progression showed higher K-trans and VE values, shown in the bar graph at the bottom. So again, the K-trans was the most useful independent predictor for differentiating the true from pseudo progression with the AUC value of about 0.8. And here are typical examples of the true progression and pseudo progression. And in the pseudo progression case, where you see the resolution of the enhancing portion at the follow-up, you could see that the graphs were left shifted for all three parameters, indicating lower permeability and increased lower angiogenesis for the pseudo progression. And we also looked at the persistent measurable enhancing lesions after the end of the standard treatment for the GBMs. And this is not an infrequent situation where you still have some measurable enhancing lesions even after the standard treatment. And we were curious how they would behave, and we were curious what role DCE could have in predicting their behavior. So we took the 24 patients with the persistent enhancing lesions after standard treatment and evaluate the three popular parameters from DCE MRI, just as in the previous study taken at the different stage of the treatment. And interestingly, we found that the progression group actually had lower values of mean K-trans and VE, and 50% percentile of the K-trans is shown in the graph here. So here are typical examples. In the true progression, you could see the values are left shifted in comparison to the non-progression group, which we speculated that as follows. So the low K-trans and VE reflect low BBB permeability, as I've mentioned in the first part of the lecture. And that has two sides. It actually can reflect the less effective temozolomide delivery to tumor cells during the standard treatment, whereas it reflected the less low BBB permeability for pseudo progression in the subacute stage of the treatment. Yes, and moving on. And it could also be used to predict the site of local recurrence, as in the study with the DSC. So similar study design, we also developed two models, one using the conventional MRI imaging alone, whereas the other one incorporated DCE and saw the performance of diagnostic role of the DCE, similar to the DSC studies. And in this example, the necrotic mass showed definite increase in the VE value, but there was no discernible increase in the VE value in the non-enhancing tumor portion with naked eye. But the model correctly predicted the site of local progression at about 1 o'clock direction of the enhancing tumor as shown in this example. This is the follow-up MR to confirm the site of progression. So again, the addition of the VE map doubled the sensitivity in the study. Lastly, touching a little bit on the role of ASL in the differential diagnosis of tumors, it could also show the difference between the GBM. It also reflects the difference in CBF between the GBM and lymphoma. So the top row has necrotic mass with markedly increased CBF, whereas the bottom one has no definite increase or even decreased CBF relative to the normal cortex. And you can guess which one is which. The top one corresponded to the GBM, whereas the second one corresponded to the lymphoma. And and knowing that the CBF from ASL can also have some diagnostic value, we investigate whether it could be helpful in predicting gene mutation, the popular gene mutation in gliomas, or even survival in the patients. So about 150 GBM patients were taken, and the preoperative CBF map of the patients were analyzed in terms of the exact normalized CBF value within the contrast enhancing and non-enhancing portions. And the values were correlated with the famous molecular biomarkers and even survivals. And the study showed that the lack of IDH mutation, which we call as IDH wild type, and the lack of methylation, promoter methylation of the MGMT were associated with increased CBF at the enhancing portion of the tumor, as shown here. So the perfusion pattern at the contrast enhancing portion and even the non-enhancing portions, they were divided into hypo, iso, and hyperperfusion relative to the normal cortical perfusion. And the hyperperfusion in both the contrast enhancing and non-enhancing portions were associated with the shortest median PFSs, as shown in these two Kaplan-Meier survival curves. And lastly, it can also be used in other hypervascular tumor, one of meningiomas, which is one of the most popular hypervascular tumor we come across in clinical practice. So we took the 27 patients with meningiomas who had undergone preoperative ASL PWI and DSA, digital subtraction angiography, and correlated the normalized CBF from the ASL with angiographic vascularity, and saw the diagnostic performance of the normalized CBF for predicting for differentiating between high and low vascularity groups, confirmed on DSA. So here are typical examples, and the left one has both of the two examples show well-enhancing convexity meningiomas. But in the first one, we do not see any increased CBF. It was rather decreased relative to the normal cortical perfusion, which corresponded to no or lack of tumor staining on the DSA. But in the second example, you see a markedly increased CBF value, and it corresponded well with a strong tumor stain shown on DSA. So in terms of its diagnostic performance and predicted angiographic vascularity, it had the AUC of approximately 0.88, and even it had a pretty good role in predicting the need for preoperative embolization in these patients. So to conclude, I've just went through very quickly the three most popular perfusion-weighted imaging techniques we use in CNS. The first one was dynamic susceptibility-weighted DSC, contrast-enhanced perfusion-weighted imaging, and the second one was DCE, and the third is ASL, relatively newer as compared with the first one, DSC. But all three are relatively commonly used, growing to be commonly used in the tumors, especially the ASL and DCE. And even ASL does not require any contrast agent, so I think it has many potentials in the future use as well. So thank you for your attention, and I'd be glad to answer any question if you have any. Thank you.
Thank you so much, Dr. Yoo, for that very enlightening talk. At this point in time, I'd like to just let all the people who are tuning in know that actually, if you have any questions, you can type it into the platform, and then we will actually post these questions to any of the three speakers. In view of time, we might probably go on into the next two talks before we take all the questions at the end. But Dr. Yoo, actually, I'm just wondering, just one quick question, because we have, you went over in quite a lot of detail these three different techniques, for tumor imaging. I'm just wondering, in clinical practice now for you, when you're evaluating, for example, the example that you talked about, looking at pseudo-progression versus actual tumor recurrence, which of these techniques do you actually more commonly use, or do you do as a combination of them in your clinical practice now?
We use DSC perfusion most commonly because it has the shortest acquisition time, and it's one of the most well-set image modality, I guess, well established. So yes, DCE and ASL both require about 5 minutes of acquisition time for now, although it is fastened a little bit nowadays. So DCE and ASL are more like research purpose in our institution yet.
All right, thank you. If you could stop sharing, then I'll just quickly share and introduce our next speaker, Dr. Choi. Thank you. Oh, sorry. maybe, okay, yeah.
Ah,
Our next speaker is Dr. Choi, who is an assistant professor at SNUH, and she'll be speaking to us today, taking us on a deep dive into brain tumor imaging, looking at the clinical application of deep learning. And Dr. Choi actually is training in both engineering as well as medicine. So I guess he has combined both of his academic interests into looking at deep learning, looking at AI techniques within imaging. And he has actually been invited to be a reviewer in multiple journals, including Nature Medicine Intelligence and Radiology Artificial Intelligence. And he has written quite a number of papers relating to deep learning as it applies to radiology. So I think we are very excited to hear from you today, Dr. Choi. So thank you very much for agreeing to speak at this webinar. Dr. Choi, please.
yes. Thank you for your kind introduction, Dr. Charles. I'm Choi from Seoul National University Hospital, and it's my pleasure to be the part of this AOSR webinar. I'll be starting off with the various clinical applications of deep learning, focusing on glioma imaging. I have nothing to disclose. So when you Google papers using the keyword deep learning, then every paper used titles such as deep learning predicts something, deep learning based on something back in 2018 to 2021. However, not anymore in these days. This means that finally deep learning has been integrated for each of the field for everyone, which is not surprising because neural networks are already proven to surpass any other algorithms when the sufficiently large data is trained by sufficiently large model with sufficiently large epochs. Likewise, in the field of glioma imaging, deep learning has been deeply integrated in everything everywhere. They're improving the imaging itself and reliability, diagnostic and prognostic performance, and also clinical workflows. Let's start with the imaging improvement. We have three topics: fast MRI, synthetic MRI, and super resolution. The first paper is about fast MRI in glioblastoma, a multi-center retrospective study of reconstruction of undersampled MRI to reduce scan times. So they used three different large training or validation datasets using simulated undersampled case-based data from the MRI by a factor of 2 to 15. They developed the reconstruction models for each of four structural sequence and undersampling rate. They use deep CNN model or model-based deep learning architecture for inverse problems, which is published in previous journal. And they tested the models using two procedures, A for single coil and B for multi-coil. They calculated the spatial agreement, volumetric tumor response assessment, and time to progression comparing the original and undersampled ones. In testing procedure B, for the fast MRI brain cohort from NYU Langone Health, multi-coil case-based data were available, and single-coil case-based data were retrospectively simulated to validate the generalizability for reconstruction models for multi-coil case-based data using the same model. As a result, the deep CNN allowed MRI scans to be accelerated by 10 times while maintaining image quality close to the original one. There were high consistency for both contrast-enhancing tumor and non-enhancing tumor volume, respectively. So structural, as you can see, the structural similarity was also comparable across URTC and fast MRI for both single coil and multi-coil. Tumor volume assessment yielded the same results, showing the identical time to progression, which is 4.3 months in median. Method demonstrated strong generalizability across different data sets, especially with multi-coil fast MRI data, where the image quality further improved. The next one is about the synthetic MRI and improving diagnostic performance for molecular subtyping. They developed generative AI using score-based diffusion model and used ResNet 50 as a classifier to predict the IDH genotype in diffuse glioma. They demonstrated the generated images according to image phenotypes, 1, tumor size, and 2, degree of enhancement. They also analyzed the effect of image features of generated images according to phenotypes. So they revealed that GAA can optimize the classification performance when nearly 400% of the original images were synthesized and added to the original ones. Specifically, the augmentation of small-sized tumors can lead to lowering classification accuracy. So they proposed the optimum number and type of imaging phenotypes that should be added to improve the performance of a classification network. Interestingly, recent Nature paper has argued that AI returns gibberish when they're trained on generated data. In other words, the AI models collapse when they're trained on recursively generated data. When the generative AI models train on real images, they generate the frequent reads of dark images. When they continuously trained on its own generated data, then it gradually forgets less common categories. So the data, remember that data augmentation with generation should be carefully approached. Next topic is about super resolution, particularly for perfusion MRI. As you know, PWI evaluates the tumor vascularity and have potential in molecular genetic diagnosis and prediction of treatment response and prognostication. However, the crude spatial and temporal resolution is insufficient to capture dynamic perfusion changes and dealing with detailing the tumor microenvironment. We proposed the simultaneous spatial temporal super resolution framework, STSR-PERF, which increases temporal resolution by 4 times and spatial resolution by 4 times. So we used neural ODE for temporal enhancement and INR for spatial enhancement, which aligns with the recent trends of physics-informed neural networks. So STSR-PERF exhibit competitive performance with other state-of-the-art models, particularly outperforming the video INR in terms of PSNR across datasets. Brain DCE MRI, Brain DSC MRI, and Brain Breast DCE MRI, and also for other various resolution factors. And this is because the integration of the physical characteristics of perfusion MRI into the model design. So this, the application of STSR-PERF model to Brain DCE MRI, Brain DSC MRI, and Breast DCE MRI, showing the enhancement of spatial resolution by 2 times and temporal resolution by 4 times. The heat map indicates the difference. Indicates the difference between the ground truth and the generated super resolution images, which is ideally black images or 0 differences. So as you can see, the model qualitatively show the best performance, even compared to video. STSR-PERF shows more blank-like images. Yes. So for temporal super resolution in Brain DSC, the STSR-PERF interpolates the interval volumes like this and better than video INR, as you can see in the STSR-PERF. Parametric maps such as K-trans and RCBB maps were compared, and STSR-PERF showed the highest alignment between the ground truth and the generated PK maps in Brain DCE MRI and DSC MRI as well, enhancing temporal resolution by 4 times and spatial resolution by 2 times. The right side figure illustrates the restoration limitations of tumors in Brain DCE MRI and DSC MRI across different temporal downsampling levels. K-trans maps showed good super resolution, including 10 times temporal downsampling. In contrast, RCBB maps cannot be restored using the model at 8 times temporal downsampling, like K-trans maps, as you can see in the left frontal lobe tumor. Let's move on to the reliability improvement. For reliability improvement, we propose to unsupervised deep learning for model-free blood-brain barrier leakage detection with DCE MRI. DCE MRI, based on D1-weighted signal intensity, can generate PK parameters such as K-trans and VE, which estimates vascular leakage or BBB integrity in various diseases, including glioma. However, the PK model-based approach deconvolutes the AIF, which is sensitive to noise, and in turn makes the PK parameters less reliable. In addition, different scan parameters such as temporal resolution makes them less reliable as well. So we propose a novel permeability map that does not require AIF measurement by utilizing autoencoder-based anomaly detection in supervised learning manner. The perfusion dynamics of normal voxels are trained using an autoencoder, and when the abnormal signals comes in, the residual signals, which reflects how much tumor voxels deviate from normal dynamics, is used to generate residual leakage signal maps, or RLS, for tumor signals, and residual vascular signal maps, or RVS, for vascular signals. On the right side, the green box indicates the normal voxel signals pattern, and the red box indicates the vessel. You can see the vessel picking here, and the yellow box can indicate the tumor of the, you can see the contrast leakage pattern here, and respectively. As a result, these are three representative cases. They showed higher reproducibility across various temporal resolution. On the right side, you can see the undersampling and truncation in both undersampling and truncation, which is called subsampling. So the RLS showed high correlation with K-trans, but more robust results in correlation in SNR and SSIM compared to K-trans. You can see that RLS maps do not degrade as the subsampling progresses, but K-trans does. The RLS maps outperformed K-trans in predicting of IDH mutations in gliomas. Interestingly, MR angiography-like vessel maps were generated because temporal patterns of the residual due to the vessels were captured using the shared pattern of the residual, which confirms the robustness of the perfusion model. Let's move on to the diagnostic and prognostic performance. For molecular subtyping, I'd like to share the results of RSNA 2021 Registration Economic Challenge. The goal of the challenge was to predict MGMT promoter methylation in gliomas using 4 different structural MRI sequences, namely pre- and post-contrast T1-weighted, T2-weighted, and T2 flare sequences. However, the top solutions showed AURC of 0.62, which is quite discouraging. To show that the MGMT promoter methylation is not predictable, we developed and validated all possible 420 different combinations of prediction models. The best model showed around 55% of AUC, accuracy, and precision in the test set. Recall was relatively high, though, about 80%, but showed large variance. In all experiments, 80% and 60% of the 420 developed models showed no significant difference with the chance level in test accuracy and AUC. In all experiments with different prediction models, the probability score from the prediction models are randomly distributed regardless of MGMT methylation, which indicates that model does not predict the methylation well. So in conclusion, these negative results may suggest that only conventional structural MR sequences do not provide sufficient information for epigenetics such as MGMT methylation. And advanced MR sequences such as diffusion or perfusion MRI are required for radiogenomics in the future study. So not everything is possible even with the use of deep learning. After a year or two, another paper which revealed the same results was published in Medical Image Analysis, which is a top journal in medical engineering. They also showed randomly distributed latent features for each class. In review papers published on radiology, they referenced our paper that MGMT was not predictable, which is initially rejected so many times because of the previous studies with false positive results. In prognostication, we developed deep survival prediction model using 3D structural MRI for diffuse gliomas. We utilized 5 different multicenter retrospective data with survival information and trained using 3 different USA data sets. The C index was 0.71 and 0.68 in the external test sets 1 and 2, which is Seoul National University Hospital and Severance Hospital. The Kaplan-Meier plots showed significant risk stratification using log rank test for both external test sets. The GRAD-CAN confirmed the tumor location with whole 3D MRI input without providing tumor locations into the model. The score extracted from the 3D CNN models, namely Deep Prognostic Index or DPI, can predict the survival after 1 year correctly, both in IDH wild type and mutant cases. For model comparison, SE Resnex 50 outperformed other CNNs in external test sets. In a joint plot, DPI and time to death duration showed significant correlation. In multivariable Cox regression, DPI showed added prognostic value independent to other clinical and molecular genetic variables. The hazard ratio of IDH was 0.04, and that of TPI was 0.036, which was comparable. And C-index significantly increases after adding the DPI. So these results indicate that the imaging or the global information is independent and comparable to prognostic data compared to the IDH, which is local information. In multimodal prognostication, they developed multimodal deep learning model to predict recurrence risk in pediatric low-grade glioma. The recurrence rates are variable, strongly dependent on the extent of resection. They pre-trained segmentation model NN unit using only 400 patients and used the latent features as deep learning extracted features for another NLP concatenated with clinical variables in the last fully connected layer. The Kaplan-Meier plots demonstrate the significant stratification for each clinical feature model, MRI-only model, and combined multimodal model. You can see the gap increases as the model progresses, and risk distributions for multimodal model was more calibrated compared to image-only or clinical-only models. In patients' cases from the test set, where baseline clinical risk factors were similar, for example, resection status, but had different recurrence patterns were analyzed. For example, the first cases were both with GTR, and in patient 1, the predicted survival probability showed decrease after 23 months, which showed recurrence in 3 years. However, in patient 2, there was no recurrence in 3 years. The survival probability stays the same as the time progresses. Finally, the incorporation of imaging features improved risk prediction. The final part is about large language models. The final paper deals with monitoring patients using LLM in glioblastoma. They investigated the potential of large language models like GPT-4 to summarize complex clinical and imaging data, particularly in glioblastoma patients for longitudinal assessment. The 5 consecutive radiology reports were provided to GPT-4 for 75 glioblastoma patients. And they used LLM GPT-4 to simultaneously produce text summary as well as the R code to visualize the disease course with therapies with graphics. GPT-4 based summaries achieved overall agreement in 91% with experts, adequately representing the disease course. Also received good quality scores, and none of the summaries were rated as having negative consequences, such as omitting relevant information or adding incorrect information. To recap, deep learning improves imaging itself and reliability, diagnostic and prognostic performance, and clinical workflows indeed existing everywhere. In conclusion, deep learning is no longer novel, but now exists everywhere. Generative multimodal models are more powerful than discriminative unimodal models. However, this does not mean that everything is possible via deep learning. Thank you for your attention.
Thank you, Dr. Choi, for your talk. I think it was really quite a good overview of all the different ways in which deep learning can contribute towards the practice of radiology, all the way from, like you said, enhancing the images to assisting in diagnosis, and also actually in summarizing our reports and how that works. But can I ask one question that I'm always curious about? Out of all the things that you presented today, how many of these techniques are you actually using in clinical practice in SNUH in your department?
I think it's very good question and excellent question, because that is the the problem that we cannot solve yet because of the generalizability. Actually, we talk about that we say that neural networks are generalizable because they have at least 1,000 cases per class for the classification network models. But in clinical practice, that kind of large numbered data set is not usually fulfilled. So especially in the rare brain tumor glioblastoma. So, but there are some working neural network models, such as segmentation or reconstruction models, which can be learned by neural networks with relatively smaller size of data sets. So in our hospital, we use AI engine with MRI reconstruction models for clinical practice to read for real patients. So I think the most generalizable neural network models are two models, which is segmentation and the MR reconstruction models.
Excellent, thank you. I think we are seeing that implementation actually has been a challenge, not just in the region, but I think around the world, because we recognize that the value of all the different AI techniques, but sometimes we can't realize that value for various reasons. I think security issues have come up in my hospital and in our country, but certainly a lot of other potential issues, like you pointed out. Sometimes the size of the data sets, whether they're generalizable, whether they're validated and properly run in the equivalent populations. So thank you so much, Dr. Choi. I think we're moving on to our next speaker. If you could allow me to just share just a set of slides to introduce Dr. Lim. Thank you. I'll just share a QR code for the post-webinar feedback form. But we won't really end this right here, because I think Dr. Choi has a question for you regarding your talk. So Dr. Choi, can I invite you to sort of ask that question directly? Yeah.
Yes, thank you for your interesting talk, Dr. Lim. Have you compared the peaks from MRI spectroscopy to multiparametric MRI, such as combination of ADC, RCVV, and VPVE?
Yeah, I mean, we did try. In fact, we in our publication looking at the IDH mutation, we looked at various combinations, not just hydroxyglutaric. We look at NA choline ratios and all that lah. But while we have some positive findings, and of course when you look at combining it with DWI, DSC, for me, at least personally, when it comes to the research, we can come to a lot of interesting conclusion analysis. But when it comes to day, I think how we apply it, some of these techniques, some of these numbers are a bit unwieldy, and so I try to refrain from applying too much of these numbers or limits in my day-to-day work. Instead, looking at the overall picture and the anatomical correlations and the history. But yeah, definitely we have been looking at this multiparametric role in a more structured within the research framework, and try to predict some of these molecular biomarkers. But so far, I think, as mentioned, I think the one that really I thought was fairly hopeful and useful was the 2-hydroxyglutarate, and we are still trying to optimize that particular technique. Yeah.
Thank you for your excellent answer.
Thank you.
Actually, there's another question from one of our participants, Dr. Evelyn Ho, regarding the additional time required to do adjuncts such as MR perfusion and spectroscopy. So actually, maybe a question to both Dr. Lim and Dr. Choi. So how do you sort of balance, I guess, there's so many sequences we can do with MR. How do you balance that sort of additional time versus maybe the clinical question of that's at hand? Yeah.
Okay, maybe I can go first. So for my practice, I'm very fortunate. So my colleagues, we collaborate with our NCC colleagues, and they have developed the accelerated DCE sequences using compressed sensing. So we can now scan a larger brain volume. Traditionally, DCE scans, because of the limitations of the scanner speed, we could only usually acquire a 5 cm slab. But now with compressed sensing and newer accelerated techniques, I think it opens up a lot of opportunities. And actually, inherently, if you think about it, perfusion acquisition is not long. It doesn't take long because you need the tracer enters the brain and washes out very quickly. So you need very fast scans to acquire enough temporal information. So inherently, these are not long scans. However, spectral in itself is different. You need to target, and depending on where the lesion is, getting good signal noise ratio and multiple signal averages, those will take time. So if you ask me, clinically, it's a lot easier from an operational point of view to apply perfusion. Spectroscopy requires a lot more expertise, a lot of more trained radiographers to apply. But we were fortunate, at least in my institution, we have trained radiographers who could do it. So we could apply both. Yeah.
I see. Well, thanks for that. Dr. Choi, actually, do you have any comments on that? Actually, there's a further comment. Maybe, I don't know whether you can sort of elaborate on that. So the further comment is, or any of the other advanced techniques that were discussed today, is there a specific workflow, or do you have a special amount of time set aside for cases that are more problematic? I mean, just curious.
It's a very interesting question. From the question, I can tell you something you also struggle. Yeah, I think a lot of it is actually on my own time. The department, because we run a very high volume department. I mean, you got so much cases piling up. A lot of times the troubleshooting, the protocoling, the post-processing is done at our own time. Where we go in to troubleshoot and go back, then rush and clear the list. I mean, that's the honest truth. Yeah.
So Dr. Choi, do you have any comment on that? Or even some of the other techniques that you discussed, some of the AI techniques which can be done in a post-processing fashion also. So I'm just curious whether you have any protocol for these advanced techniques we've discussed today.
Well, yeah, maybe generating PK maps, as you mentioned, can be reduced using AI techniques, particularly physics-informed neural networks, which is recently introduced. Yes. That may be enhance the clinical application of those kind of neural network models. Yes.
Okay. Well, yeah, thank you. I think actually one of the things that I took away from what both of you said in your responses is that actually there are a lot of newer techniques that we can utilize that can reduce the time taken for some of these advanced techniques, and actually maybe it may unlock more clinical value. So when we can start doing some of these methods and they don't take up as much time, and we can start doing them for more cases, I think we will actually also learn a little bit more. Right now, we are limited sometimes by our technology, but some of those limitations hopefully will be reduced or will go away in future. I'm mindful of time. We have reached 1 hour 30 minutes already for this webinar. So at this point in time, I just want to really thank the three speakers, Dr. Yoo, Dr. Choi, and Dr. Lim, for sharing, taking time out of their busy schedules to really share with us things that are both very exciting, but also very practical. And I think based on the questions in the chat, you can see that there are a lot of people who are interested in seeing how to better use these advanced techniques in their day-to-day practice. So hopefully today's talks gave them a bit of insight in terms of how to do it and how to do it practically. So thank you very much to all three speakers, and thank you very much to all the participants as well for taking the time to listen to the talks today. Please fill in the feedback form when you have time so that you can get your participation certificate. Thank you.
Thank you.
Thank you so much, Dr. Charles.
Thank you.
Thank you. See all of you the next time.